4, 3, 2. Good evening, everyone, and welcome to the 7th Conversation That Matters series in collaboration with the HSE. This evening's conversation will finish around 7:10, and we have an option for questions throughout the course of the discussion. So if you go to your screen, there's an icon at the end of your screen that allows you the capacity to ask a question to the panel. And I would welcome if you would do that. My colleague Tina Joyce will be collating all of the questions coming in, and we have put aside protected time at the end of our conversation to answer those questions and put them to our panel. My name is Caroline O'Regan. I work with the Institute of Leadership in the Royal College of Surgeons in Ireland. I am very pleased to have this opportunity to continue our discussion conversations, and tonight we're going to be talking about person-centeredness, specifically organisations that look after their people in this COVID-19 crisis. This is a particularly challenging time for leaders across our health services and care delivery areas. So I want to welcome our panel of experts. Welcome back Dr. Miriam Colleran, who is a consultant in palliative medicine from St. Bridget's Hospice and Naas General Hospital. I would like to warmly welcome Dr. Veronica O'Doherty. Veronica is Head of Psychological Services and Principal Psychological Manager at Tallaght University Hospital, and Dr. John Fitzsimons, who is the Consultant Paediatrician in Temple Street Hospital in Dublin and is also a Clinical Director for Quality Improvement. And finally, I would like to give a big warm welcome to a colleague, Miss Lucy Nugent, who is the CEO of Tallaght Hospital here in Dublin, this evening to talk about leadership in a crisis and how healthcare organisations are looking after their people. Last week we had Dr. Philip Crowley, National Director with the Quality Improvement Team in the HSE, together with Professor Donald Brennan, talking about quality and leadership. So it's a nice introduction to talk about leadership challenges in one of Dublin's largest, busiest academic teaching hospital, to be fair, and to get an insight to having a conversation with two colleagues who have worked together over a long period of time. So Miriam, Veronica, Lucy and John, it is really lovely to see you, and thank you so much and welcome to this evening's discussion. So I'm going to pass you over to Miriam now. Thank you.
Thank you, Caroline. Veronica, I'm delighted to get to speak with you today. Living through a global pandemic is a new experience for us all, including those of us here in Ireland in healthcare. We were accustomed to a certain type of clinical practice, as well as a certain type of lifestyle, and there has been a dramatic change quickly to both of them. Many of us were watching the events in China and Italy unfold. While maybe not universal, I think for many of us it led to feelings of fear. Fear for the future, fear of change from the familiar, fear for our loved ones and ourselves, and a fear of the changed clinical practice we were expecting. We too are people. Dr. Ira Byock, who is a past president of the American Academy of Hospice and Palliative Medicine and author, recently stated that we, as clinicians, we are whole persons caring for whole persons. Veronica, huge thanks again for being here today. I'm keen to discuss this further with you. But firstly, can you chat with us a little about the initiative that you led out in Tallaght University Hospital?
Yes, I'm delighted to be here. Initially, when I was watching events unfold in China, I, having in a previous life worked a little bit in Sydney and in Ireland in intensive care units as a nurse before I became a psychologist, I had an idea that things might be very difficult. And I've also been doing some research in trying to support staff to cultivate resilience. So with that whole combination, I began to search all the literature on the Ebola epidemic and the SARS epidemic. And I saw from some of the research that came out from that healthcare staff, clinicians and other staff had vulnerabilities. Exactly what you said. They had a fear of catching the virus. They also had a fear, particularly, of bringing the virus home to people they cared about. And that was a really big added stressor. And also, subsequent to that, they also had issues in relation to when they did catch the virus or were ill and recovered, they had issues so kind of stemming from feelings and fear related to going back to work after that. So there were a lot of phases to that. So what I decided to do was put in an immediate response to that, which was to try and get our psychologists to set up a on-site staff support system. And I researched again what was out there in terms of emergency supports that had been put in place previously. And of course, you know, looking at America, having been through 9/11, and they have a lot of earthquakes and all sorts of disasters and fires, they were quite, they developed a lot of models, probably based on army type models, looking at psychological first aid. So I thought this model is really good. And in fact, in our hospital, and Lucy will know this, the occupational health doctor there, Alex Reid, had instigated a training for some of us last year on psychological first aid, which was something I had suggested for normal events and incidents that staff had. So we decided that we'd do a call service that was 40 minutes long, or people could do it for 10 minutes if they liked, and that it was responsive insofar as we were initially put it out for 7 days, including weekend times. So people could choose when they wanted to call us and we'd call them back. So it was almost like a calendar. And the other thing we did was we looked at resilience training, specifically a very short focus training to capture the elements of resilience that healthcare staff have in spades anyway. This is something we learn from the get-go.
Yes.
But having said that, a pandemic like this, unprecedented, one in a century event, none of us were prepared for this. So it tests the resilience of everyone.
Okay.
So does that give you broad, and
Sure.
that training was like a Zoom training. So all our staff had to kind of quickly become very familiar with the training. I got all my staff trained up on the psychological first aid model. We used the John Hopkins training, which was free and that anyone can do. And I just kind of set it up, and I kind of thought to myself, knowing Lucy as I did, and knowing the compassionate approach that our senior managers had, that they'd stop me at any stage if they weren't sure this wouldn't work. So it was a case of kind of going ahead, getting the support as I went, and knowing that, yeah, this is moving along. This is good. It's happening.
Great. Great. So of course, what I'm hearing you say is what we're trying to avoid is burnout in our healthcare workers.
Yeah.
In the recent article in the New England Journal of Medicine, Physician Burnout Interrupted, the authors Hartsband and Groupman explained that burnout is toxic for patients as well as physicians because it's associated with loss of empathy, impaired job performance, and increases in medical mistakes. Family and friendships also suffer as EHR's demands invade doctors' homes and consume the time once enjoyed in vital relationships, worsening emotional exhaustion. Can we chat a bit more about that, please, Veronica?
Yeah, and I mean, this is my favorite topic. You know, empathic distress. It used to be called compassion fatigue. It's now called empathic distress. And some of that new kind of thinking on that has actually come from Buddhist psychology. Very, very interesting stuff from scholars in Buddhism. And what they're saying really is that we experience, when we experience empathy, which is being able to understand somebody else's distress and feel it. And we can feel this in our body, in our minds.
Sure.
And if we experience empathy without being able to take a compassionate action, then we get distressed. And that's called empathic distress.
Okay.
So that compassion is the answer to empathic distress.
Okay.
So continued empathy, like a flow. I mean, in fact, Matthew Ricard, who is known as the happiness monk, described when he was taking part in research with Tanya Singer years ago in Germany, and they were putting him under a scanner, and he was told to imagine, they were doing neuroscience experiments, and he was told to imagine a difficult situation. So he imagined when he was back in the Romanian orphanages, and he felt very distressed because he was an hour under the scanner or whatever, and he was thinking about how he walked through this very sad situation with children very vulnerable. And then when he came out, he said, oh my God, I can't wait to get back in there and do a compassionate meditation, a mindful self-compassion meditation for myself, so that I can alleviate all the triggers, because they could see lights coming up in certain parts of the brain that were showing this was distressing. So, and look, it triggers as well, I'm sure, our survival, because these are very old concepts that, you know, where human beings actually survive with compassion, helping them to survive in terms of the things they do, even for burials. And again, that brings another issue up for us at the moment.
Absolutely, absolutely. So, but I think it's important to emphasize, Veronica, what I'm hearing, as you know, the Trauma Group UK have done a lot of important and interesting work on supporting healthcare workers through traumatic experiences like this. And I think it's very important to say what you're describing is very expert work. This is highly nuanced expert work, both in the delivery, in the evidence base behind it, in the delivery, and in getting the timing right of these interventions. Would you like to speak to that for me, please?
Yeah, I think there's so many aspects of it. There's the flagging the concerns in advance. There's the actual, you know, what happens on the ground, and timely responsiveness to that, which is really important, and encouraging staff to engage in that in a confidential way. Protecting people's anonymity, I think, is very important, but yet having a process where you can guide them to get further help if they need it. And then afterwards, it's about recognizing as well that not all traumatic events cause problems. People have growth moments. People can get over these things quite well. It's a percentage of people that don't. Now, even in one of the more recent papers from COVID-19, I think it was Lei et al., the Chinese paper, said that 70% of healthcare staff reported distress.
Okay.
So you're absolutely right about the timeliness of it, and having the support systems in place afterwards are vital.
Okay. So I suppose I'm hearing two different things there. What you're saying is, it sounds to me like the narrative is very important about this, Veronica. As Michelle Obama has said, words matter, and about how we frame our discussions about COVID and on the impact it can have on healthcare staff. But also, Veronica, what would you recommend for us doing going forward? Do you think this type of support or resilience training should be continued?
I think it should be done for every person going into the healthcare staff as part of induction and ongoing. I think there should be resilience training in particular, and that can develop as we learn new things and see what works. But certainly to introduce people to the concept of how they can work through a resilience plan for themselves should things go wrong. So it's about preparedness in a way.
Okay. I think we're just actually, I mean, there's just so much more. And this has been such a rich conversation, Veronica. I hope you'll come back to us again, and other times we can actually chat more about this,
Love
because
to.
there's just so much. And thank you so much for sharing.
Thank you.
John?
You're welcome.
Thank you, Veronica.
Thanks, Miriam, and thanks, Veronica. That was super. And I agree, so rich. And it's my pleasure to maybe build on that now with Lucy. And thanks for joining us this evening, Lucy. Are you hearing me there, Lucy?
I lost you there for a second, John.
Oh, sorry.
I'm sure you said something nice about me.
I'm just welcoming you, and I'm just saying what a nice opportunity it is to chat with you. And absolutely. Lucy, I suppose that the theme of this evening is around person-centeredness, and I suppose we've been hearing Miriam and Veronica there talking about some of the person-centered work that you're doing in Tala and focusing on issues like burnout. And I suppose, you know, in quality improvement and in quality thinking, you know, we think of person-centeredness as being something that applies to patient care, directly to patients. But I think the more I think about this, and I'm interested in your perspective as a CEO, you know, there's a really thin line in terms of person-centeredness. You know, is it for staff or is it for patients? And I think it must be applied to staff in equal quantities. And I suppose I wanted to just explore that with you. And what does that term person-centeredness mean to you as a CEO?
I suppose I was thinking about this the other day, and we were fortunate, I suppose, as an organization. We actually, towards the end of last year, we actually took time out to say, well, what are we doing as an organization as part of our 5-year strategy? And the one thing that we came up with was our vision statement, which is people caring for people to live better lives. And it was at that point someone says, you know, that applies to staff as well. And of course it does, but we tend to focus on the patient first and foremost, and that's our natural inclination as healthcare workers. But COVID really has, for me, actually almost put the staff ahead of the patients, because I found it quite a big ask to basically say to our staff, we are knowingly putting you at risk. It's well known that healthcare workers have a higher risk of contracting COVID. So to ask, that's a big ask of people, and Veronica touched on that, you know, cause a high level of anxieties. It's an unprecedented thing that we faced as a society. So how can you look after your staff? Well, you know, there's the basic things of the likes of PPE, making sure you have enough. And our director of finance took it on as a personal champion to make sure we had adequate stocks, because I want to be able to reassure staff, you don't have to worry about that. We're sorting that out. And we're trying to make sure that enough things and supports on the practical level were in place. But then the really important, what a lot of people describe as the soft side or the soft skills, which I think is actually slightly condescending, because just because it's maybe considered a soft skill, it's so important during periods like this, and generally just in life. So we have dynamic people like Veronica who come up with innovative approaches, and that's been right across the organization. My job has been very easy. My job is just basically to support people to come up with great ideas. And the one thing I think I learned as well is that you cannot communicate enough during periods like this, because people are hungry for information. The problem, the challenge for me is that we were getting, I mean, I'm sure like everyone else, our inboxes were full of emails from HPSC, the HC, the department, all very important, but to try and sift and sort the relevant, important information for staff, so they didn't have information overload, because that in itself is a burden. So trying to make sure that, you know, my CEO emails were actually of value, and rather than, oh, here's another one from another email from on high. So making sure that they had value, and actually we were actually blown away by a lot of the supports that were being offered to the organization. Simple things like electric scooters. I mean, who would have thought of that? But how do people get to work when they're concerned about taking public transport because they felt that they were at risk? So again, trying again to make sure that people knew these offers were there and a support to them.
And I suppose, you know, by prioritizing, first of all, you know, the PPE and the making sure that people are physically looked after, then I think that allows you then the right to kind of to start talking about the soft stuff, you know, the stuff that people maybe don't think is so important.
Well, in the end of the day, if you didn't have things like PPE to protect you, the staff aren't interested in maybe considering other supports. And again, like, we were very lucky. Things like we got these pods where our ICU staff could go, and basically it's like a little space age pod that comes over, and they could have, they were so popular that actually a time limit had to be put on them. But then another member of staff, one of our admin staff, her daughter is an ICU nurse here, and she came up with the idea of Novid rooms, which basically were where you could go to rest and recover, and you were not allowed to talk about COVID. And she contacted, you know, the likes of Arnott's and Woody's, and came up with, you know, some nice, soft furnishings, which I know are technically IPC non-compliant in a hospital, but in this exceptional circumstance, and soft lighting, some diffusers. And again, all I had to do was agree. And they went off and did all the hard work and made it work. And again, I'm really popular with staff, because even just taking those 15 minutes out, just to, you know, even just have a little weep on your own, if that's what you want to do, or even just close your eyes, or, you know, or read a book, or just do nothing, you know.
So Lucy, are you telling me these weren't all your good ideas?
No.
But, you know, how do you do that? How do you encourage those ideas to come forward? You know, because I think people have forever been having good ideas, but maybe, you know, for a long time they've not been able or willing to bring them forward. And is it COVID that's brought them forward, or what? You know, what's happened that?
I think, in fairness, like, in Tala University Hospital, because, you know, I think our history is well known. It's had a rocky history. There's been, you know, a lot of changeover in CEOs. It's the staff. I think the response to that is they have a real can-do attitude. So, I mean, I was really impressed when I came here 5 years ago now as the Chief Operations Officer. I'm only in my current role just over a year, but there is a can-do attitude, and it's about fostering it. You know, I think it was you, John, when I did my diploma in the RCPI, that said, you know, steal shamelessly if there's a good idea. For example, for our Director of Nursing saw on Twitter about, you know, Sending Love, which the Royal Hospital in Donnybrook. It's an email facility for families to contact their loved ones. And again, we did credit them, but
We've lost your sound there, Lucy, I think. Can you
hear
me?
How to manage a disease. Sorry, yeah, can now. Yeah. Can you hear me?
Yeah.
Yeah, sorry. So I think, you know, as healthcare workers, we're used to sharing. So why not share good ideas? And I think, as an organisation, as a leadership team, I think the executive management team, we're very open to people coming forward.
And Veronica alluded there to the fact that you know each other from obviously your previous role, and you'd worked with each other. And I think she maybe alluded to as well that the importance of relationships, you know, and knowing people, and then when the chips are down, being able to call upon those relationships. Well, is that important?
Yeah. Oh, I can give you a great example of that, insofar as we wanted to move our oncology day unit off-site because we felt that they were a vulnerable cohort. So I was able to pick up the phone to the interim head of the Institute of Population Health across the road in the Russell building and ask her permission. They were closed up. Could we take one of their floors? And it all happened in days. Now, that was the one thing that COVID did do. All the red tape and, you know, having to, you know, do a business case and all those things that I, as a CEO, normally ask for, went out the window. And, you know, those relationships are really key in a crisis. Being able to pick up the phone and say, I need help. You know, we even did it with PPE. We borrowed from each other. You know, it is about having a little black book.
And just to say, I would have known from having engaged with Lucy at monthly or 3 monthly meetings when she was COO. If you don't mind me saying, Lucy, I would have known that you had a compassionate nature and you had an awareness of, you know, what mattered for people. And, you know, even on a previous project with chronic disease programs that we linked into the community, when we were up for a particular prize in that, Lucy showed up, and that's unusual and very appreciated.
Well, thank you.
Fantastic.
Thank you. But I think it's really it's about team. You know, it is about everyone pulling together, and right across the system, I think we've shown, you know, from Paul Reed down, together we achieve much. And my biggest fear is that we're all going to revert back into our silos. We're all going to start, protectionism potentially coming to fore again, whereas there's been some really innovative things that have happened, and if we could build on that, I always say never waste a crisis. So it's how we can build on it.
And I think a lot of what you've both been talking about, I would class as resilience, and I think we've maybe grown to see resilience as something that you tap into after an event, but I think it's the resilience that you tap into during an event and even before something happens. And I suppose that might be my question to both of you now is how do you see what you've learned through COVID supporting you in the months and potentially years ahead, where we're going to have the constraints of COVID on us in terms of being able to have people wait in spaces, or we have to use our facilities very differently, but also the backlog of demand and all these things. How can we take what we've learned over the last 7 or 8 weeks and bring it forward?
We've actually started talking about it here internally now, the recovery phase, that, okay, there may be a second wave, but there's going to be that period in between. And it was interesting, one of our consultants said, I can do 90% of my outpatient work now as a virtual consultation. And we were, oh, okay. Now we need to look into that more. We need to know, well, what's the impact of that? Is it what the patient wants?
Yeah.
Because just because we can do something, it may not necessarily meet the needs of everybody in that relationship as well. So I think we have a long road ahead. And I think, the other thing is people are tired. Staff are tired. I think everyone, everyone is in, battle mode. You can achieve an awful lot. But then when you get to this lull, for want of a better word, how can you make sure that people take some time off? How can they recharge their batteries? How can they adapt to the new normal? And we're still working through what that new normal is, And
I think as we were talking earlier, Lucy, there's still a lot of work to be done in terms of patient work with COVID-19, post ICU. People who've done well and come out of the ICU are going to need a lot of long-term support. And some of that can be done, even regular compassionate phone calls to those people at home, on the phone or virtually if they're able to use IT equipment. And I think checking in with them and constantly checking in with staff as well. There also needs to be a post-conversation forum for staff, maybe similar to, I kind of liked what they did in the veterans piece for PTSD in the Army, where they had forums set up where people who went through these experiences could talk to each other and communicate with each other and share those experiences. So that's a stepping stone. And I think you asked about what learning could happen. I really think we need to not be afraid to stand up, step up, show leadership in any direction for new ideas and see if they get traction, rather than, I think sometimes the red tape is an impediment. Some of it's necessary, but some of it's an impediment. And it's amazing what COVID allowed, the hospital to do in general. And, people never cease to amaze me as to how they could do that and step up, and such innovation and such courage in doing that. I would say courage.
Yeah. And there was a lot of, I suppose, hidden heroes as well. I mean, we had our ICT department work for 3 weekends in a row to make sure that we deployed 200 extra laptops and remote access to staff so that they could either cocoon or have their childcare issues. They did it without a second. Our facilities department put up screens where we didn't have screens from the point of view of even our cash desk, so that our canteen workers were protected. So there was an awful lot of goodwill, and how can you thank people for that? It's something that I'm trying to think about, you know, and again, but I think you know that builds relationships with people that may not have actually worked together previously. And I think, you know, it's a bit like Storm Emma built resilience and amongst and team built. You know, I spoke to people that I hadn't spoken to before, and this event has done the same. It's forged relationships both within the hospital and externally as well. And I think if we could come together in a more integrated way, which is the vision for healthcare, I think an awful lot could be achieved before the blame game starts, you know.
Oh, thank you both. That's been super. Miriam, do you want to add anything there or ask, or shall we hand over to Tina?
And I think that was incredibly rich. Thank you. Thanks to the three of you so much. It'd be great to see what Tina, if Tina has any questions. Yeah.
Okay, thank you very much, everybody. So there's lots of comments and questions, and you've answered some of them as we've been going along around how do people really sort of taken with this idea of agility, of preparedness, and this innovation, and how to maintain that culture of innovation. And what do you think, I suppose, Veronica or Lucy, would be really important in establishing and mainstreaming that culture, not allowing that to kind of disappear or just evaporate when we get back to normal?
I suppose I mentioned earlier that we had actually in our own hospital had looked at our strategy, and one of the things, we have 6 pillars, but one of our pillars is basically research and innovation, and we're trying to now actually put it front and central. We've actually built an innovation hub that we're in the process of commissioning, with the help of Amazon, actually our near neighbour, and again it's partnerships like that. It's like there's an awful lot of health tech companies that are very keen to partner with healthcare facilities. How can we do that safely? How can we actually add value? How can they add value? So again, we're actually working on our own innovation strategy, and actually with the help of our foundation, we're lucky we're getting support for an innovation manager. So we're actually putting our money, I suppose, where our mouth is, and having a dedicated space actually in the main atrium of the hospital. So again, it's front and central. We want people to consider, and every single person is an innovator. The innovation manager's role is to foster and draw in those ideas. It's not to be the innovator. It's every member of staff is, and that's how we're starting to approach it. We're at the very start of our journey, and we've a long way to go. But I think it's about constantly asking, how can we do things differently that add value?
Okay. And I think there's also you know, what I found is that a sense of trust in the professionals, that they really, you know, experienced people know what they're doing, for the most part, and they bring with them a richness of learning and skills that were absolutely utilized during this crisis. And I think they need to be used more and more, or recognized more and more. I'm not saying they aren't, but I think they need to be recognized more. That we often look to international people, but I think we have an awful lot of massive expertise here in our hospitals, in our health system, in our people. So recognition of that and allowing that to flourish, whether it's by the innovation hubs, it's a great idea, and by research, but also encouraging it at every level. And in a way, somebody mentioned when we were talking earlier, pre this, the COVID flattening of hierarchies. And I think the hierarchical systems in hospitals, while somewhat necessary, and I get that, you know, but I think sometimes they can be an impediment.
Miriam?
Lucy and Veronica, I was wondering, would you speak to the huddles? You have mentioned the huddles to us before, and it'd be nice to chat about them this evening.
Well, just very briefly, what we discovered, well, huddles is a kind of a new term that's come out, that is about people grouping together to have a conversation about something and to sort something out. And in the context of COVID-19, we were trying to provide something for the ICU team. And one of the nurses, Shona, suggested that we were going to go in maybe and do a 5-minute meditation or something. We were trying to do something pre their shift and then post their shift. So what she came up with herself was that they would be happy to meet based on some of the ideas we gave them and look at some positive thoughts and things going forward into the day, and then the same at the end of the day.
Okay, thank you.
I might just come back in there again, if that's okay, because there's just two other comments. And I think probably, Veronica, when Lucy was talking earlier on about her little black book, and I presume this little black book is in relation to work-related issues. Somebody has just come in to say, what about, Alison has come in to say about some of the staff that are working from home and working remotely, and they've been doing that now for a couple of weeks. So they don't really have the same connectivity as being on site as they would have had in the past. Is there any advice that you can give for people who are remote working so that those relationships don't become eroded or don't become lost over time?
Well, certainly from our end, I've instituted weekly telecon meetings with my whole team, and they're a meeting for an hour where we talk about everything, and we also have maintained supervision together. We set up a WhatsApp group where we communicate all the quick issues into, and we also, I mean, my team have my phone number, so they call me on my mobile at any time. I've made myself available, and we have created a support system for each other that can be done to maintain contact. But I do think it needs to be led, and people need permission to do that.
Okay. Okay.
And there's also additional, even like we tend to focus on the administrative end of working from home, but even if you're working remotely off-site, we're using, for example, red zinc glasses. So basically a clinician, a doctor in with the patient can put the glasses on, and somebody remotely can actually see that patient. The National Ambulance Service are using them. So we have 10 of them in on trial at the moment, and they've been very successful. Again, giving that extra support to the person at the bedside, but also for the person at home feeling involved, that they're still contributing to patient care.
Okay. And just one final question then, and then I'll hand back to the panel. Lucy, there's a question in around, I suppose you mentioned telemedicine earlier on, and now how one of the consultants was talking about doing more of this remote. Are there any sort of legal aspects that we need to be thinking about in relation to that initiative?
Well, actually, the HSE are actually now, I think it's called Anywhere, Consult Anywhere, and basically that they're looking at all of the GDPR compliance, which we all need to be careful of, and that also we ourselves have an SOP of how you do that. How do you actually engage with the patient, and how do you record that? You know, all those things need to be worked through, rather than while somebody may have gone off and done it very quickly. The interesting thing actually is that if you're doing either a teleconference or a telemedicine, you end up actually sometimes having to, it takes longer in some instances, because you actually have to ask more questions, because you don't have those normal non-verbal cues that you can pick up when you're face to face. So again, you know, you can do it, but we want to do it right. So again, there's a lot of guidance coming out continuously on that, and we're trying to make sure that we're following that.
Okay, Caroline.
Can I just say thanks, folks, for sharing all those stories, and just we're very much trying to capture those stories as well. And if you're on Twitter, just if you have good stories, just to tag it with the hashtag Our Health Service, because I think all of us want to capture those stories and learn from them. And I think having a good bank of examples of our best selves, I think is going to be really useful in the days ahead. So thank you so much.
So I suppose, look, I've 1 minute to finalise our discussion, and thank you so much. And as I promised you, it actually flies past. So a few of the key takeaways are that, as Veronica said, the resilience training, I agree, should be part of induction for every person into the organisation, and maybe that's a learning going forward. And some of the beautiful learnings from Matthew Rickard, the happiness monk, around how do we look at that growth model? And empathetic distress, I thought that was a really critical, important point. Given with the stats that 70% of healthcare staff are feeling distressed in COVID, and how do we continue with that support? And then I loved the whole thing around Lucy's supporting all of these initiatives as the CEO. And I suppose going into the future, how can you thank the people and the goodwill? And a lot of that was based on relationships that you had built. But notwithstanding that, some of the models of care which will probably change into the new world. The example he gave, that 90% for one consultant, he is looking, or she is looking at outpatients which are virtual. And how do we do this? And is this what the patient needs? And that people are getting tired now. So in the post-COVID, how do we, the battle is over, or, we're coming to the end of it. So how do we look after our people? And the importance of relationships, the importance of communication, the importance of giving that space to people. And Lucy, you said about your little black book. I'd love to see your little black book. I love the really simple things around, you agreed to allow 15 minutes for that space for people to have that collective downtime. And what really gave me confidence was the fact that you said that Paul Reid, the CEO of the HSE, has talked about together down the road, how are you going to work to sustain these really good practices, which is insightful because Paul has agreed to come in to one of the conversations later on in the month. So it would be good to put that question to him. So I'd like to thank you very much. I'd like to thank you as a magnet organisation that demonstrated through your practice compassion, looking after your people, allowing them to flourish in a very unprecedented, challenging set of circumstances and environment. And it's a pleasure to know you and to hear what you have done. And thank you so much. So thank you to our panel. And I will say good night and thank you to John and Miriam. So
thanks very much.
Thank you.
Thank you. Thanks very much.